Okay, so just a quick thing again about the surgical consent. So you always want to make sure that this is in the chart, or you mean in the electronic medical record, the EMR. Um, Sometimes it's, you go through this in your pre-op clinic visit before the patient is actually in pre-op the day of surgery, post-op day 0. And sometimes it's not scanned into the chart. So the day of surgery, you're trying to look for this thing and it's not in their chart. So what do? You just go get another one and you go over the same thing over again and have everybody sign everything. So you have it again. So anyway, I just wanted to stress that point in case it ever happens to you. So, but as a student, you won't be really doing that. So excuse me, pre-op and intra-op meds. So this varies a lot between surgeons, procedures, specialties, all that kind of stuff. But I put some stuff that we always had all the time. This is just as a PA, us ordering. Anesthesia has a whole bunch of other stuff that they do. So pre-op, you give Ofirmev or Tylenol, PO or IV. It depends on the procedure. Usually it's IV. You have to be really careful giving any type of foregut or bariatric GI surgery patients any type of pills before surgery, because you definitely don't want to be cutting into a stomach and have a big old pill in there. So, and it affect your staple line. So you have to be really careful. Scopolamine patches in pre-op. So you can do Zofran. Usually do that in intra-op, but patients who are going to have a lot of nausea, who've had it in the past, or who are worried about it, you can do a scopolamine patch, and I'll show you that in a little bit. But it's this tiny little patch that goes behind the ear. It's about 1.5 milligrams. You apply it 72 hours. I think total you can apply it for that long, but you do it on arrival to pre-op holding, or you also do it post-op prophylaxis, nausea and vomiting. But patients can also put this on the night before surgery at home as well. So also an intra-op. So this is when the patient is like right before, possibly on the table with the anesthesiologist, and we're kind of prepping the room still with them in there before we're about ready to knock them out under general. So you always give antibiotics depending on the procedure. We in bariatrics like to give NSAF, just 1 dose. If they're pen allergic, so they can't have penicillins, we give Levo. You give heparin, 5,000 units sub-Q for DVT prevention. This is something that you give patients a lot for surgeries and also after. If they have bleeding risk, sometimes you hold heparin, and sometimes you're in there and you see that maybe they're a little bit oozy and you're doing surgery on them and they're oozy and bleeding a little bit more. You hold back the heparin, and you may hold back the heparin after the surgery while they're recovering in post-op. So that's just a little, just a little tidbit there. So Zofran, you can give 4 milligrams IV, or promethazine, 25 milligrams, given 30 minutes prior to them waking up, starting to wake up from anesthesia. So if you kind of stop the nausea and vomiting head on. So PA/OR responsibilities. There's a lot, and it varies per procedure. So prior to the start of the surgical case, you go to the OR. Again, like what I talked about, you make sure all your supplies are there, all your equipment's there and ready. You ask the scrub tech or the circulating nurse if they need any help. You always want to be a big help, especially a student. You pick up stuff, pick up trash, do whatever you can, grab things, learn as much as you can. Try and pick everybody's brain without being, a pest, but you can do it. So once the patient is wheeled back by anesthesia, usually it's always the anesthesiologist who brings them back because they've kind of pre-medded them a little bit. You help with the transfer of the patient onto the operating room table. So that is a teamwork, bringing them over. The operating table is really, really skinny. You can get pretty big patients, especially in bariatrics. You don't want them falling off the table. So you have them scoot over, and they're already hooked up to IVs, and you got to help them with their gown. And they're always self-conscious about not flashing anybody, but you're in the operating room. It's, you're going to see things. So anyway, so you help them over with everybody's teamwork. I always tell the patient, take your hands, feel the edge of the bed, and try and center your bottom in the middle and your body in the middle. And then anesthesia likes the patient up, their head back a certain amount and elevated. They have certain wedges and things like that or they may roll up blankets to get them how they want them, their head and neck, so they can intubate them properly, however they want to do it. So you want to help out anesthesia as well. So also, and we'll talk a little bit more about these, you apply sequential compression devices, or SCDs, to both lower extremities. Depending on if you're doing a surgery on one extremity, of course, you're not going to put it on there. But this helps blood flow to the rest of the body, keeping it going throughout surgery. So you prevent DVTs and PEs. So we'll talk a little bit more about that later. I'll show you a picture of them. You also, again, assist anesthesia at bedside. You can help them place an IV. You can assist with intubation. You'll be right there by the head of the bed. The nurse will teach you how to do that, hopefully. You can apply cricoid pressure, which helps them during intubation so they can see through the trachea and get in there. Make sure the patient has received all their necessary pre-op medications, IV Tylenol, antibiotics, heparin, like what we talked about. You can place Foley catheter if needed. This is something you're going to get good at as a PA in surgery. The nurses will try and run in there and do it really, really fast. But this is something that you should totally learn. It's different for men and women when you're placing Foleys. It's different when the patient has a larger body habitus and you may need 2 people, but it's all done under sterile technique. So hopefully you can learn that and place them. So you also want to position the patient and apply restraints. So we'll go over some of that 2 common positions just really briefly, and then the restraints. You shave the surgical site if they're a little furry. Help others with additional last-minute tasks. If you need a step stool, grab a couple. They're always like on the side of the room or in a corner. Grab them and place at the bedside where you want to stand, but make sure you're not in the way of where your surgeon wants to be, or in the way of equipment or the bed, or the surgical scrub techs, Mayo stands, and big stands that they're putting all their instruments on. You do not want those in the way. So wherever your surgeon's standing, wherever he's going to want you to stand, you can bring those steps up, because I'm a shorty and sometimes I would put 2 up, 3 across. My surgeons like steps. So I always try to prep their steps where I knew they'd want to be and where I'd want to be every time, so we could just go in and do the surgery and not worry about it. You participate in a timeout. We'll go over what a timeout is. Help others, gown and glove. I'll show you a video of that. You first or second assist your surgeon, right? Because you may have a fellow or resident, so you may be bumped down to second assist so they can learn, which is a good thing. You want everybody to learn. So perform wound closure and apply dressings. You place drains. So a lot of times PAs, we close at the end of surgery. We're the ones putting on the dressings. We're applying the drains. We're doing the Dermabond glue after we suture over some deep dermal sutures, things like that. So you also, this is what I did. I don't know as a student if you would do that. I transfer the patient from the operating room and transport them to the postoperative unit. So this is something that I would go in and I'd be with the patient all the way from when they wake up in the operating room, wheel them out to recovery, and we'll go over a little bit of that too. Wheel them out into recovery and talk and do my handoff with whatever is the recovery nurse who's at the bed where I'm supposed to go, that's already been assigned to the patient. There's boards that will show like the patient's name and where they need to go in recovery. So you go straight to that bed and you do your handoff. So your handoff goes over what surgery is performed, how the patient did, what medications are going to be needed, what you're going to be ordering for this patient, where they need to go after recovery, if they're doing a hospital stay or going home later, how many surgical sites there were, how you dress them so the nurses know how to take care of them, what to look for. It's just a lot of different things, but it's nice to give that handoff to them. And also in regards to pain meds, you need to know what you're giving and let them know as well. Or if the patient's diabetic, if they have sleep apnea. If the patient has sleep apnea, they have to go up. They have to be taken care of on a different floor just because of the risk of them not breathing very well, especially when they're getting opioid narcotic medications for pain. You need to make sure. So you also will write the op note, quick op note, and I think Joy is going over that with you, how to write the op note and place orders. So this is the SCDs that I had talked about. So the DVT prevention. So these assist maintaining blood flow of the lower extremities to prevent DVT formation. So they're wrapped around, and you can see this little picture and like the little box D, right, lower right-hand corner. They're wrapped around both patients' lower extremities. There's Velcro. It's connected with a tubing to a machine. It's usually placed under the operating room table. So you want to make sure that that's not directly under it, because if you're trying to lower the bed down, it's going to get stuck, sometimes crushed, and the surgeon will get really upset because he can't move the bed the way he wants it in order to get an angle that he wants. So he or she. So you need to be careful of that. Always ask the nurses how to apply these. Depending on the procedure, it can be placed on the upper extremities as well, but it will always avoid the arm or the leg with an IV. Okay, so because this is going to constantly squeeze and compress and squeeze and compress, and you need to make sure that you're avoiding that. So you also want to make sure the tubing is connected properly. The machine is turned on because sometimes they're battery operated and people forget to not plug them in and charge them. So you can put these on, and then you've had a patient in the operating room for 6 hours, and you haven't been using these, and that's not good in the long run. So double check each leg. So you turn it on, you look at the machine and make sure that it's on and blinking and showing each leg, and you also go up to each leg and you feel and make sure that it's squeezing. So and then each one comes in all different sizes because everybody's legs come in all different shapes and sizes. So small, medium, large, they're usually in one of the cabinets in the operating room, as well as your Foley catheters. Those are in there too. So you can pull those out and look at those. So Foley catheters, these are put in sterile technique. They can come with a temperature probe and without. Some surgeons like to know what the temperature is of their patient throughout the surgery, depending on what procedure they're doing. So one with a temperature probe, one without. You need to ask your surgeon. Usually the scrub tech will know. The OR nurse usually places it again, but if somebody is a little bit more difficult, they're morbidly obese, they had a lot of body habitus, you may need 2 people to retract the pannus, the lower portion of the abdomen that's hanging down, or the labia, and other things to place a Foley cast. So some people need to retract back the skin, and then the other person is placing the Foley. So it may be kept in or taken out the day of surgery or the day after. So that all depends on the procedure. And patient positioning. So this varies widely. You can see that in this picture, this looks like an employee that just took a picture and did it. I pulled it off the internet. So you have a lap belt. The lap belt, it attaches to almost like little rings or little attachments onto the table, like these little metal bars. And you always want to make sure that it's not in a portion of the metal bar that can slip off, during surgery. It's in between 2 little things. You'll see what I'm talking about when you're actually in the operating room and you're doing this. But you have a lap belt. You also have arm boards that you have, and you can attach the patient's arms onto those. Make sure that anesthesia has already gotten their IV in. Sometimes they don't like you to go ahead and put those in already if they haven't gotten their IVs. And you always will talk about patient positioning here. Here, let's move on to the next slide and we'll go into it. So most common positions are supine, prone, low lithotomy, lateral decubitus. The patient is positioned, you put safety belts and straps on them. You never leave a sleeping patient unattended if the patient is not strapped in, okay? Patients can fall off all the time. You have to be very careful. You never just walk away. So somebody always is standing next to the patient with their body up against the bed, just kind of making sure until the patient's belted in, okay? So make sure to check your location and placement of belts and padding and Foley catheters and placement in relationship to the genitals or other regions, because you can crush certain areas with these belts. You can pull the Foley catheter a little bit, even though you've already inflated the balloon. You just have to be really careful. You have to be very aware of everything around you. So pressure points are padded with either foam pads, gel pads, wedges, pillows, blankets, anything you can find. bariatric surgery, our patients are very obese. Surgery takes up in like 1.5, 2.5 hours. And so you want to use a lot of padding everywhere. We use a lot of foam pads, and you can rip them up into different shapes. You put them under the knees, under the heels, under the arms and wrists to elevate them. So nothing is in like a complete extended position. Everything's kind of naturally where it should fall if you were like asleep on a bed yourself. So nothing hurts or is strained later. Joints, knees, wrists, elbows, again, supported with either foam rolled up or pillows. Put pillows under the knees most of the time. Anesthesia will ensure proper placement of the patient's head and neck. That's the anesthesia's department. So be careful touching head and neck and moving things there. They will be very upset if you start getting into their area without asking. Surgical instruments can sometimes be placed like close or near to the areas of the neck, the face, on the other side of the drape. So if you know that you're going to be placing surgical instruments up towards that way and out of the way, you can give the anesthesiologist a foam pad so they can place it over the patient's face, things like that, or anesthesia might just do that. So patient safety is of the utmost importance, including potential injuries to nerves, circulation, or musculoskeletal related that could occur from improper positioning. So you always have to make sure, look at the patient and go, is that going to hurt in about, 20, 30 minutes or longer? Maybe we should, move it more into a more natural position. Okay. So skin preparation, clean to dirty. I love this picture here. So if there's hair at a surgical site, shave it. Okay. You don't want hair in that surgical site. Clean out the belly button lint. You apply your antiseptic in a solution in a circular motion from the surgical site outward. So you can see, like, if you're doing an abdominal incision here on the left, or surgery, you're going to go from the belly button and take your prep stick. That's, if you see on this top picture, that's ChlorPrep. You take your prep stick and you start from the belly button and in a circular motion, like clockwise out, over and over and over. You don't want to really, you can overlap a little bit, but not a lot, and never go backwards. Okay. Cause then you're contaminating the other spot. So, in regards to this prep stick, so your surgical prep can be either this chlorhexagluconate or iodine preps. There's some other ones, and these are the most common. I always use the ChlorPrep stick. It's a pre-filled snap stick, almost like a light stick, the little glow sticks that you would use as a kid or camping. So you crack it, and then you see the little handle there. You can squeeze that little handle over and over and over it, and then kind of shake it really good back and forth. And the prep will come down on that little sponge, which is usually yellow, and it turns orange because the prep is kind of an orange color. And then it'll come out, and then you can start, doing your prep. Sometimes it's just swabs and some other techniques. Now, another trick that I have, if you have a lot of hair and you've shaved it, if you have a really hairy guy, and women can be hairy too, and you shaved it and you have all these tiny little hairs all over the surgical field, just get those big 3-inch rolls of tape. They always have them in there. And you can take a strip, tear it off, fold up like the very tip ends of the tape. So you have like little grabber ends. And then you can just take it back and forth over the patient's surgical site or belly. And you'll get all the hair off like super quickly. So you won't have to worry about it. Okay.